The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone, and welcome to tonight's Interprofessional Virtual Grand Rounds. Before I introduce myself, I'd like to bring to your attention the poll that should be displayed on your screen. If you could please take a minute and just click on the response that best applies to you. It asks, which profession or role do you represent? All right, I'm going to close the poll. And so joining us tonight, we have 10% of our participants are students, 20% are coming from the field of medicine, 40% work in dentistry, and 30% said other. So I'm going to open up the second poll and get on with my introduction. So my name is Michael Tarr. I'm a fourth-year medical student at New York Medical College, and I'm the AADMD Virtual Grand Rounds Task Force Director. So the Virtual Grand Rounds Task Force is a group of 7 medical and dental students and residents from around the country who are passionate about improving education of medical and dental professionals on how to treat individuals with IDD. Let's take a look at our second poll. And this poll asked, in which stage of your career are you in? So for this poll, we had 22% of our participants said that they are in health professional training, 11% are in residency, 56% are currently practicing, and 11% of you are retired from practice. So a pretty good mix. I'm going to open up the last poll and continue to introduce tonight's presentation. So the AADMD Virtual Grand Round sessions seek to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. At the end of the presentation, please stay on with us to ask any questions you have for the presenters. Questions can be submitted through the Questions tab on your gray control panel on your screen. In addition, you can download tonight's presentation from the Handouts tab for future reference or to follow along. All right, I'm going to close the poll and share with you one last time. And so this last question asked, what do you hope to gain from this webinar? And 11% of you said you're looking for learning foundational healthcare concepts for individuals with IDD. 56% of you said to gain interprofessional perspectives on healthcare for individuals with IDD. And 33% of you said to gain pearls from complex and challenging clinical cases. All right. So tomorrow you will all receive a link to a post-webinar survey. If you could just take a minute and review this survey for us. It takes about 3 minutes on average, but it's very helpful for us to improve future webinars. It's pretty quick, and the feedback you give us also can let us know what future topics you'd like to have presented on, and also help us build and change the webinars to kind of fit your needs and what you guys would like to get out of it. And with that, I'd like to present tonight's presenter. Tonight's Virtual Grand Rounds is being presented by Dr. Carrie DiCepolo. Dr. DiCepolo graduated with her bachelor's in science from Rensselaer Polytechnical Institute. She received her doctorate in dental science from NYU College of Dentistry and completed a fellowship in pediatric dentistry from Yale New Haven Hospital. She obtained her MPH from Columbia University later on. She is well represented through her multiple publications and has given many presentations on various topics, including the treatment of children with ASD. Her volunteer work and involvement in multiple professional organizations and advocacy groups speak to her altruistic approach to treating her patients. Dr. DiCepolo is currently working as a clinical educator at UConn School of Dental Medicine and she's the dental director at Connecticut Children's Medical Center. And with that, I'd like to hand the floor over to our presenter, Dr. DeCepolo.
Thank you so much. Thank you for having me this evening. Well, tonight we'll be speaking about medical considerations for patients during dental care, and basically I'm going to dive right in. So my patient that I'm going to be speaking mostly about tonight is Rebecca B. And as you can see from this picture, she's kind of a happy girl. She's there with her mom, and she's visited our clinic for many years now at the Connecticut Children's Medical Center. Her social history is that she's 14 years old. She lives at home with both her parents. She's just started 8th grade in middle school. She has 2 brothers, 2 sisters. The primary caregivers are her parents. She doesn't have pets. Her home is pretty healthy and good. She's wheelchair bound, able to communicate verbally, a little developmentally and cognitively delayed. And she does have trouble eating by mouth. So what she will usually have is pureed type food. Her medical history is obviously a little bit more complex. Her primary diagnosis of spina bifida at birth and the subsequent global developmental delays have occurred. She wears corrective glasses. She has obstructive sleep apnea. She has restrictive lung disease, and along with her other diagnosis, she has a neurogenic bowel and bladder. She has musculoskeletal problems, including decreased functional mobility and endurance. She has skin abnormalities, and her endocrine findings are pituitary dwarfism and precocious development in puberty. And she has a latex allergy, which is pretty common with patients with spina bifida due to their several surgeries in their lifetime. So moving on to her surgical history, you can see that she's had quite a few different interventions for her various physiologic issues. And I just want to point out that during one of the surgeries, she had to have an emergency tracheostomy because she had adverse reaction to rocuronium during the procedure. And so that's something that later on in the presentation I'm going to bring out a little bit, but just to see that she's has pretty significant diagnoses, and she also has had quite a bit of medical treatment. She takes medications to help with her breathing, and basically I just wanted to point out that as dental professionals, it's important for us to keep on top of what types of medications and what are the primary diagnosis and subsequent diagnosis for our patients, because the procedures that we perform in our offices, although they may be routine for the healthy individual, can actually interact with some of the physiologic problems that these patients may have. And also there are side effects to medications that patients might be taking, or interactions, drug interactions that we have to be aware of. So this is important to us. So average oral health care for the persons with special health care needs is very much catered towards who the individual is and what their limitations are. So when we think about limitations, we think about physiologic limitations, you know, how are they going to maneuver in our setting? Psychological limitations, you know, are they going to be able to tolerate the types of things that we'll ask of them? Parent beliefs and caregiver attitudes can very much drive how appointments, how dental care is provided and maybe not provided. And obviously the complicating medical factors will also dictate how we approach oral health care for these patients. So what happens at a dental appointment? So a typical dental appointment, for those of you that maybe have gone to the dentist before, you know, sometimes people have different emotional feelings about going to the dentist, but typically we expect that our patients are going to physically enter into the dental clinic, sit in the dental chair, cooperate for an oral exam. We're going to give directions and ask for tasks to be performed, like dental radiographs. If we perform procedures like a dental cleaning or fillings, that requires a certain amount of compliance and cooperation to be accomplished in the traditional dental setting. So for considerations for persons with special healthcare needs, we might alter those appointments. We might make them shorter, specifically directed towards specific goals. We might actually provide a desensitization time period where the patient could actually get acquainted with the office. We ask the patient or caregiver if there are any specific needs of the patient. You know, and I'll talk a little bit more about Rebecca's special needs, but we will alter our appointment and cater to her depending on what her specific areas of concern are, or specific challenges are. I would urge everyone to speak directly to the patient. I think that transcends all of healthcare. When we have a person with special healthcare needs that presents to an office, we typically may gravitate towards having the conversation with the primary caregiver because they might be the medical historian. I think that it kind of skews sometimes that appointment a little bit. So having that conversation with the patient and speaking directly, making eye contact, and maybe altering your speech pattern and your questions to have an effective communication with them. In the dental setting, one of our ways that we overcome anxiety or fear about some of the dental procedures you might perform, we actually will demonstrate some of the procedures in a pantomime sort of way, maybe on the bracket tray, or maybe we let the parent or the patient hold some of the instruments, or just to see what we're going to be doing. We use tell, show, do, so we describe what we're going to do, we pantomime it, and then we go ahead and do the procedure. Sometimes the success from demonstrating and coaching and urging a patient through the procedure is a surprise to the patient and the caregiver, and we'll go into that a little bit more as well. So Rebecca has had multiple medical procedures, and the first question is she willing to come into the dental clinic on her own? Sometimes, depending on people's cognitive ability and their understanding of what's going to occur inside the dental setting, we've had children and adults that are not super excited to walk in through our front door. So if she were that type of person, we might consider desensitization visits, multiple short visits that are short in duration, to provide an iterative process of goal achievements at each visit. So we might work up to coming into the clinic and looking around and seeing how the clinic looks, and then let them be on their way, and then actually have them back once a week for several weeks to work up towards getting in the chair, opening your mouth, and different things like that. Rebecca was pretty excited to come in. There were moments where the last couple of times that we saw her, she's a little bit older now, there are moments where she gets a little teary, where she doesn't quite understand what the next step is. And so we'll have to back up and describe to her what we'll be doing. This desensitization is really important for patients like this. Her decreased functional mobility and endurance really limits as far as asking her to stand up and go sit down in the dental chair. That's obviously something that she's not capable of doing. So, some parents are willing to pick up their child and put them in the dental chair for us. Sometimes it's not an option. So are we going to say, well, we can't treat you because you can't sit in the dental chair, or are we going to alter our approach to provide care? So we opted to perform the dental exam and the cleaning in her own wheelchair, which we do quite frequently. And we're really lucky that Rebecca had a fantastic wheelchair that can lean back, and she's got cool joysticks on either side, so she has control and she can angulate herself the way that she feels most comfortable. So that was an important accommodation that we could make in our dental setting. And not all dentists and not all dental offices, even though they may be mandated to see special healthcare needs patients, have the width in their operatory, so they don't have the physical width or the physical dimensions in their offices to accommodate larger wheelchairs coming in or larger wheelchairs going into the operatory, or if they need to readjust the patient, you know, they may not have room to maneuver to perform their procedure. So not all dental offices are built the same, and that's something to consider. Due to her diminished breathing capacity and her ability to lie on her back is limited, she gets uncomfortable. So when we were working, we did short periods of dental work. If we were doing our scaling or our cleaning, we'd take a break, let her sit up and talk and kind of regroup, and then we begin again. So what that does is it makes the dental appointment a little bit longer. So that's something to consider as well, that you might not book this patient for the typical time period, and not all dentists are willing to accommodate that sometimes. So it's something to consider. One other thing is because she has, you know, decreased muscle tone and ability to masticate and kind of maneuver her tongue and her lips and things like that, it's imperative to have constant suction when we're working in the mouth and removing debris to prevent any aspirations or leaving anything behind that could potentially cause her problems. So when we look at Rebecca from a very, very close-up dental perspective, we're looking at her hygiene. We're looking at her toothbrushing and flossing. That is the gold standard for us in prevention. You know, how well you take care of your teeth is going to bode well for how long you'll keep your teeth into your future life. So we're going to talk about her oral hygiene, and you know, this is very common. Who is doing the brushing? If Rebecca has decreased manual dexterity and she maybe doesn't have the spatial reasoning to understand getting each area of her teeth, you know, who's helping her to do the brushing? Is she doing it on her own? Is mom doing it? And is there a caregiver? Is there help at school? Who does that? And that's important too, because we're finding out, if it's getting done. And, you know, usually if a person is getting routine brushing, they're usually a little bit more open to having us look in their mouth. They're a little bit more willing to sit for an oral exam. And we also know that they're performing those preventive measures that are so important. With Rebecca, we asked about any discomfort or pain or anything of concern. She's verbal and she's able to articulate some of that. Mom also helped and pitched in with some of that, answering those questions. So certain people that we may see with IDD may not be able to verbalize. So our clinical exam and being able to perform the clinical exam appropriately and well becomes crucial in helping to prevent any emergent problems in the future, because we can do an exam, come up with the appropriate plan of care. So what are we looking for when we look at a dental, when we perform a dental exam? We're looking for dental decay, obviously, the cavities. We're looking for those things. If we can catch them while they're small, we can care for them before they become larger and potentially cause infections that can lead to facial infections and hospitalizations. In someone that is nonverbal or not able to articulate problems, infections can become insidious and become a life-threatening emergency very easily. So we're looking at Rebecca now, and she has diet risk factors that are not so high. She eats a very healthy diet. She might eat pureed food, but for the most part, it's healthy. She does pouch food in her cheeks. So again, because her diminished ability to manipulate the food and to clear it, she will eat food, and actually it becomes kind of lodged in the vestibule and the maxillary posterior region, where the food will just kind of pouch there. And what that means is you get extra tartar or calculus buildup. You can get cavities in that area if there's not a caregiver in there making sure that's getting cleaned out. She also has low salivary flow that we saw on exam, and most of the time this is due to medication. So you saw that she was on albuterol and other respiratory medications. So if her salivary flow is diminished due to the medications, then she loses the buffering capacity to prevent against dental caries. So that's something to consider, and that plays into her risk of acquiring dental disease. On our exam, we were able to get an x-ray, and we see that her wisdom teeth, so if you're looking at this radiograph in the slide, on the right and left-hand side, you could see that there are two teeth on the mandible that are angulated differently than the rest of the teeth. So when we see impacted wisdom teeth like that, your average kid 9 times out of 10 will have them extracted, because potentially they can cause, they can damage the adjacent teeth, or they can cause pericoronitis. But we'll go into that a little bit more about what our plan would be for Rebecca. We're looking for gingivitis and periodontal disease, any signs of that. So you could see that Rebecca on the last slide, you can see she has pretty good crowding of her teeth. So that just means that the teeth are not perfectly aligned in the arch, and they may overlap each other. And that just means that she's a little bit more, it's a little bit more challenging to get teeth clean because of that overlap, and there's a potential risk for periodontal problems in the future. So our treatment options for Rebecca. So we performed the dental exam and the hygiene. She got a little teary for the x-rays, but we were able to coach her through, and we were able to accomplish that. So in the office, with those accommodations that we made, seeing her in her chair, we were able to accomplish those preventive procedures, which is fantastic, because Rebecca can go on in the future receiving those preventive measures if she's stable. So that's something that will help her in her oral health in the future, and it also helped to prevent maybe some oral diseases like periodontal disease or other things that would require elevated care. So that's fantastic. So secondly, we saw the overlap and the crowding of the teeth, and we'll get questions from parents about orthodontic care. Can Rebecca get braces? Well, braces are, can help reduce periodontal issues. If we straighten out the teeth, you won't get as much food trapped. Unfortunately, the downside is orthodontic care requires multiple long appointments, and that can be challenging sometimes for some of our patients, especially Rebecca. If she can't sit for very long, or she can't tolerate being open very long, it could be hard for her to go through that. And over the course of several years, which orthodontic care usually takes, every 6 weeks, every 4 weeks for 2 or 3 years, you're in the office going through these appointments. That's challenging. The parental input and perceptions are really going to weigh into the orthodontic care. If the parents are really invested in pursuing it, then it may be something that can be accomplished with the right provider. Again, the orthodontist would have to be someone that is able to accommodate special needs. Cost is always a factor, and yeah, so braces are on the table, but with a lot of conditions. Oral surgery, so her impacted wisdom teeth, that's another area that we would have to address. She could have potential complications from no treatment. When the teeth are angulated like that, they can cause resorption or problems on the adjacent teeth, and sometimes you can get communication because there's no bone over those teeth. So it's soft tissue, so sometimes you can get communication from the oral cavity. You can get a pericoronitis, which is just a localized inflammatory process that can develop into an infection, and if that infection gets larger, it could potentially turn into a cellulitis. The percentage of the time that happens is, low, so we would have to weigh the risk of treatment versus no treatment, and what would be the best option for Rebecca. So just to review a little bit, on the left-hand picture is Rebecca with those are her lower front teeth, her lower incisors and premolars. You can appreciate that they're not well aligned and they're a little bit overlapped. So that's her. And her gingiva, for the most part, is pretty healthy. She's coming in for cleanings routinely, so we don't see a lot of buildup. The next two photos are actually just projections of what can occur. So these are not Rebecca. But what can happen over time if the caregiver isn't in there helping brush, and the patient goes for long periods of time without getting dental cleanings, you start to get this buildup. And what happens is you get an inflammatory process from the bacteria that are kind of stuck in that plaque and calculus, and it actually starts to deteriorate the periodontal ligament that holds the tooth in the bone, and you get osteoclastic activity in the bone that also will start to take some of the bone away from the tooth. So they're all running away from this infection, and what the end result is, you get teeth that become mobile and non-viable and will have to be taken out. So having routine preventive care coming for those cleaning visits, so important to prevent this process. So with periodontal treatment like that, for people who have advanced periodontal disease, they can be very lengthy appointments. There'll be multiple appointments. They might have to lay a flap. They can cause bacteremias. They're doing deep scaling and root planing. Usually pain medication and pain control is necessary, so there's injections of lidocaine or some other local anesthetic. So if we have Rebecca come on routine cleanings on a routine time period, we can get ahead of that and not have to go into the periodontal treatments that those people with a more advanced disease would have to have. So again, you can imagine that if she had to go through those types of appointments, it would be challenging for her. Orthodontic care, you can appreciate from the photo that orthodontic brackets are very little. They're very nicely aligned. And what happens is those little appliances are can be dropped in the mouth, and they can cause problems. If they drop into her mouth or have any issues like that. So we would like to be careful with patients that could potentially not have the ability to have protective reflex and prevent those from going in the back. I'm gonna stop for 1 second. Sorry about that. So the Invisalign is a secondary option for patients. Again, it just matters that they're able to tolerate the procedure. So what can potentially happen if we don't maintain the teeth? So for persons with special healthcare needs, if they lose the teeth, edentalism, they can, from advanced periodontal disease, they can have they would have to have dentures fabricated. And what that means is they would have all the teeth extracted, which is a more advanced procedure for a person that has special healthcare needs. They can have swelling and pain. They may not eat well during that period. If they don't have teeth, the diet will change, and you can imagine how that would affect their physiology if they're not able to masticate certain foods. Phonation can change, may cause social anxiety, and the dentures require multiple appointments again. So if we can stay ahead of this and not go into this area, it can be helpful to the patient. Extraction of teeth require pain management, and pain management can be controlled with local anesthetics and post-operative medications. Patient's anxiety can be controlled with effective communication, anxiolytic medication, sedation, or general anesthesia. But for persons that may have cognitive delays or not be able to communicate effectively, surgical removal of impacted molars may not be something that can be done in the office setting. It may be something that requires sedation or general anesthesia to help manage the patient through the procedure. When you extract these teeth, they require a surgical flap, removal of bone, requires mouth opening for quite a long time, upwards of 60, 90 minutes. So you can imagine that a person like Rebecca may not be able to tolerate that length of a procedure, and that might not be an option for her. So we have all these dental things that we like to do, and what we typically do before we perform any of these types of activities is we will reach out to our physician colleagues. The dentist will need to understand how procedures will possibly cause problems or interact with medical conditions, and dentists in their training are encouraged to have good relationships with the patient's medical providers to discuss these medical dental interactions. Common questions that dentists may ask physicians might be about altering medication regimens to accommodate dental procedures. For instance, bleeding is always an issue with dental procedures. So if a patient's on anticoagulant therapy, we might ask you to alter it or stop it. And how will it affect the physiology of the patient? It's something for you to discuss with the dental provider, and the pros and cons of doing that. Sometimes when we take some of our patients for general anesthesia, they need to have MPO status prior to the operation. So MPO is 6 to 8 hours depending on the patient, and sometimes they're required to take medication during that time period. And which medications can we leave off for that day? Which medications can the patient do without for one day? Local anesthetic dosing is always a consideration for people with renal or liver problems. And what are the general contraindications to using local anesthetic, if there are any? So this is something that I might ask the medical provider if they have any insight to this. Even though I have the medical history and I'm aware of the different problems, sometimes the medical provider has obviously has more specialized knowledge in that area, and they might have some insight for me. One of the big questions that we do ask as dentists is about SBE or antibiotic prophylaxis for protection against transient bacteremias. Now, that can be patients with cardiac abnormalities, or it could be patients that are immune suppressed or on lifelong therapy for transplants. There are a lot of different reasons for us to be concerned about that, because most dental procedures, we do cause transient bacteremias. If we're scaling, if we're doing a filling, we might inject, even though it's a sterile needle, we might inject through spaces that could potentially end in the bloodstream. So it's important for us to understand and know that. And that's maybe questions that you get as a medical provider out in the field. We do ask for medical clearance for procedures before we go under general anesthesia or for moderate sedation. Typically, most dentists, besides oral surgeons, are not able to admit or provide a medical clearance for general anesthetic procedures. So we ask for our medical colleagues to provide that information of the health of the patient for us to perform those procedures. So what can you tell your patients? As a medical provider, if your patient, the caregiver, is saying, "Hey, I need to go to the dentist," what advice would you give to me? The pre-planning, pre-appointment questions that are important for us to know from our medical providers, that the patient can, facilitate this conversation, or the parent caregiver can facilitate the conversation. We might ask, how does the patient tolerate their medical visit? So how do they do in the waiting room when they come to the doctor's office? And how do they get into the office? Are they a willing patient? How does the patient react to strange environments or strangers, or even immunizations? How did the patient tolerate that in the past? So if we get that history from our medical colleagues, just the patient's overall behavior, it can help tailor the dental appointment a little bit better, and maybe make that first appointment or future appointments go a little bit smoother. So, just finding out those accommodations that the medical colleagues might be making. Health history information. I can't stress enough that as dentists, we do small surgical procedures on patients, and even cleanings. We can cause a significant amount of bleeding. So we need any information that is relevant to adverse events subsequent from transient bacteremias. If patients have a history of aspiration pneumonia, so you can imagine those patients with periodontal disease, big chunks of stuff stuck in between their teeth. If we use ultrasonic lavage to remove all of that, and this is a patient that has had an aspiration pneumonia in the past, we could be putting them at risk for another aspiration pneumonia because they are not able to tolerate those big chunks of calculus going the wrong way down. If the patient's immune suppressed, what is the appropriate time if they're under cancer therapy or anything else? When is the appropriate time for us to be performing procedures? If they have muscular hypertonia or dystrophies, positioning of the patient can be so crucial, and maybe there's information that the medical provider can give to us about that. You can appreciate as well that if we're manipulating the head and neck region, depending on how severe the hypotonia is, we can potentially be causing physiologic problems to patients if we're manipulating the head and neck in any way. Bone disorders, if they have had any fractures or anything like that, anything that whether they have a pin in them from a recent surgery or if they have osteoporosis and they're prone to fractures, and what that means for us if we're performing oral surgery procedures. Obviously, bleeding disorders, we cause bleeding quite a bit, so we want to know if a person is going to have a problem with coagulation. If the patient takes food by mouth, it makes a big difference to us as far as understanding if they're going to have an oral aversion or if they're going to be capable of us or tolerating us working in the mouth. These are all things that we may write a consultation to our medical colleagues to ask about. Okay, so recommendations to our caregivers. What do they need to know about the dental office prior to the dental appointment? I would discuss proper time. When's the proper time to bring in the patient, depending on what accommodations need to be made, when more staff is available, if there is a less busy time of day that the patient can be accommodated more reasonably. If there's physical space and accommodations in the office, what can they do if they're going to have to move their regular area of performing hygiene, or they can have to move it to a new room to accommodate a wheelchair, and just discussing the medical history. Family structure and support. We always advise that the primary caregiver be present at the dental appointment. It usually helps to facilitate and calm the patient. Any supportive family members or healthcare workers that are with the patient a lot, it's great if they come along as well. Anything to kind of ease any fear or anxiety. We can't stress enough having a regular dental provider, the continuity of care, the prevention aspect are so important to the overall success of oral health in these patients. And also the better relationships allow for a better overall experience, positive outcomes, and future acceptance of oral care. So when we talk about accommodations during dental appointments, we kind of triage them into 3 or 4 areas. So we have our different IDD patients that, no accommodations are necessary. They're happy, they're ready to come in. They pretty much perform every activity just like your average dental patient. Then we have other patients, maybe a little bit like Rebecca, where we do minimal accommodation. I might perform the exam, the cleaning, and the wheelchair, and besides that, I'm still doing my traditional exam, cleaning, x-rays, and everything else. Just a little bit of accommodation can go a long way. Moderate accommodation, it's when a patient, needs help managing their physical behavior and psychological disabilities. That usually comes in the form of some form of restraint. So whether it be parents just helping hold hands, we also have mouth props that we can help to hold open the jaw if the patient is not super willing to stay open. We can also use a protective stabilizer. It's a protective wrap that is commonly used in emergency departments in certain situations, a Velcro wrap. Advanced accommodations might be working towards sedation and general anesthesia. Each patient should be assessed at the initial visit to determine what is needed, what type of accommodation, but most importantly, it should be consistently reassessed. Some patients mature, you know, when they're 5, they can tolerate one thing. When they're 25, they can tolerate a different thing, even if they do have autism or CP. Sometimes they can mature through different areas. They may develop new skills. A lot of fantastic programs are out there that work with persons with special healthcare needs to develop life skills. So maybe, you know, as they go through that in school, they might be more capable in the dental setting. Or just simply, they might become accustomed to dental care. You have that continuity, you have that relationship, they're getting used to you. So when we talk about like the nuts and bolts of these accommodations, with minimal accommodations, we have short, quick appointments, desensitization. Moderate accommodations may be papoose or protective stabilization. You can use nitrous oxide or mild anxiolytic medications. Advanced would be moderate sedation, which, just as an aside, moderate sedation is dependent on the airway evaluation and the patient's physiology. So typically in outpatient setting, I would recommend ASA1 or ASA2, have moderate sedation in the outpatient ambulatory setting, just because typically people with craniofacial abnormalities might be more prone to airway collapse during sedation. And you can imagine that the emergent situation with a person who has already a compromised airway becomes even more challenging. So really making sure that your patients that may be seeking that type of sedation in the outpatient setting are the appropriate patients to be treated that way. I do prefer for most of our patients that have these compromises that they go for operating room general anesthetic, because there is a full complement of emergency personnel available and the airway is more controlled. So when we look at minimal, you know, it's just, you know, treating the kid in the environment that maybe they're a little bit more comfortable in, or the adult that is wheelchair bound, you know, just accommodating ourselves to work around them. Moderate, this is just a picture of what a protective stabilizer looks like, and what it is the Velcro around the hands and then around the torso and the legs. We'll use this for patients that we need to get an exam and need to see what's going on, especially if it's in an emergency situation where the caregiver or the patient is reporting pain, but the patient isn't able to tolerate just sitting and opening for us. So this is something that is necessary at times. Advanced procedures would be general anesthetic. So we have the full behavior management done. The patient is comfortable and sedated, and we can complete all of the work for the patient on that day. So we could do cleaning, we could do x-rays, and we can do all their fillings, extractions under the general anesthetic in one visit. And sometimes that's the best option for some of our patients. So when we're making decisions about treatments, the parental and provider priorities and attitudes can serve as facilitators or impeders to oral care. So if the parent is not on board with the treatment recommended, you know, care may not be given. And provider priorities, if the provider is not someone that can accommodate special healthcare needs, may be an impediment to patients receiving the oral care that they need. Another problem is parental and physician lack of awareness and knowledge that hinder individuals with special healthcare needs from seeking preventive dental care. Especially if you've got a very complex medical patient that has a lot of challenges in their life, oral health care kind of drops to the bottom of the priority list, which may be reasonable, but when it comes to removing pain and removing chronic infection in the mouth, it might lead to better outcomes and the overall physiology of the patient, because they might be eating better, they might be more comfortable. So even though it may not be an easy thing to fit in when you've got that person with a very complex schedule, it's really important to still make it somehow intertwined into the medical care. So one of the statements that I found in this American Academy of Pediatric Dentistry clinical guidelines was, persons with special healthcare needs may express a greater level of anxiety about dental care than those without a disability, which may adversely impact the frequency of dental visits and subsequently oral health. And I think that's an interesting statement, because it may be true. You know, if they're going through, like I was saying before with Rebecca, that if you're going through multiple medical appointments, maybe you're super heightened against going to the dentist, you're super, lots of anxiety. But I like to think that the majority of people are just not excited about going to the dentist, and just because someone has more challenges, more physiologic, more cognitive challenges, I don't think that putting oral health to the bottom of the bucket because we don't want to cause distress or problems, you know, with anxiety is not always the best choice. So I think that there are ways to work around and coach and help persons with special healthcare needs kind of overcome some of those anxieties or overcome the obstacles. So, I just wanted to point out this article, Parental Perceptions of Oral Health Related Quality of Life for Children with Special Healthcare Needs, Impact of Oral Rehabilitation Under General Anesthesia. So 73 kids underwent oral rehabilitation. So that means they went to the operating room to get all of their dental care, x-ray, cleaning, fillings, extractions, whatever. And they did a survey just to find out, you know, the most frequent reasons why they went for oral rehabilitation. And so a lot of these people were having spontaneous pain, difficulty eating, worrying about eating and nutrition. So the parent was concerned about that. The severity ratings for oral symptoms, daily life problems, and parental concerns were significantly lower, and scores for oral well-being were significantly higher following oral rehabilitation. So what this kind of shows is that you have a group of people that are having a health issue, having anxiety, having problems, and that the general anesthetic, you know, solution was a great outcome for them, and it definitely was helpful to them, but it does not come without risks. The standard of care for traditional dental patients are semi-annual dental cleanings and exam, periodic radiographic evaluation, treatment of disease when it's diagnosed. And so the standards of care for persons with special healthcare needs should be the same. But the challenge exists that prevent the same frequency as traditional patients. So maybe the person is not able to tolerate coming into the office every day. So does this mean that we take these people every 6 months to receive general anesthetic, to do cleanings and x-rays? Not necessarily. That really should be based on the provider's discretion, diagnosis, dental disease risk assessments, and the parental attitudes towards it. So even though general anesthetic and OR is a great help and a great solution for many of our persons with special healthcare needs that cannot tolerate traditional dental treatment, it isn't always the best answer, because it's not something that can be doled out routinely, and the higher frequency of general anesthetics means higher risk for adverse events. So the question becomes, when is the risk of the procedure greater than the risk of the disease? And that's something that we have to weigh out, and we might reach out to our medical colleagues and say, hey, these are the things I'm seeing, you know, what is your input on this? What do you think about that? So evidence-based dentistry from the American Dental Association is an approach to oral health care that requires judicious integration of systematic assessments of clinically relevant scientific evidence relating to the patient's oral medical condition and history, with the dentist's clinical expertise and the patient's treatment needs and preferences. So that's great, but the problem is with evidence-based dentistry as an evidence-based medicine, we don't have a lot of systematic prospective trials or randomized trials that can tell us, what the efficacy of some of our procedures are. So if anesthesia complications can range in 1 in 20,000 cases in a hospital setting with a full complement of emergency providers, to a higher frequency of emergent events in outpatient settings. So you can have more emergent events in the outpatient settings, and they don't have the same amount of trained personnel. So what I'm basically saying is that you have evidence that sedation and general anesthetics are great for patients, but we don't really know with special healthcare needs who are dental patients specifically what the frequency of adverse events are, and we specifically don't know in the outpatient setting those statistics. During a previous medical surgery, Rebecca had bronchial spasms and required emergency tracheostomy during the surgery. So did she have an anaphylactic reaction to the rocuronium? I don't think that was specifically stated, but that's a pretty severe problem that can occur. So even if she was undergoing a spinal surgery that could potentially help with her overall quality of life, having emergency airway collapse is quite frightening. So is this the type of person that you would take multiple times under general anesthesia to do cleanings? Probably not. Is it warranted for us to take out wisdom teeth on her and deal with the possibility of an emergency problem during the procedure? I don't know. I think that some people, there isn't enough literature out there to say that those horizontally impacted wisdom teeth cause problems or life-threatening problems in this many people, so therefore this is why you should be doing it. So evidence-based dentistry and our special needs patients really, even though the American Dental Association can come out with a grand statement like they did, it doesn't really add up because we don't really have all the facts. So the evidence-based dentistry is lacking on providing evidence of the efficacy of performing prophylactic exodontia and prophylactic dental cleanings under general anesthesia. So it's something to consider as well. So our case selection of who we're going to take for general anesthesia, or what type of procedures we're going to do on our different patients is important. Can an airway be properly assessed in outpatient settings? So you can appreciate that some patients, Rebecca was really great. She'd open big, even if it was for short periods of time, we could get a good look. Not all of our patients are able to follow commands that way, and not all our patients are willing to have us look. So, evaluating airways or looking for things like this little dental abscess on a moving person who refuses to kind of open for you can be really challenging. And can you absolutely rule out that they don't have a problem or they do have a problem, they don't have a problem that would mean that they have to go to a general anesthetic appointment. Post-surgical follow-up and care can also be hard to achieve because of the stress, the time, and the parents' perception of value of follow-up care. So case selection for these types of procedures is crucial. The Americans with Disabilities Act proclaims that the dental office is a place of public accommodation. Dentists are obligated to be familiar with these regulations and ensure compliance. This may not always be the case due to lack of understanding and education to familiarize dentists with evidence-based approaches in dental care and professional obligations. So the Surgeon General basically pointed out that it's persons with disabilities, their oral health can be very complex, and there are lots of barriers we know about seeking oral health care. So some of the barriers we have are the providers, general practitioners may not have formal training and may not be willing to provide care to special health care needs, and lack of reimbursement incentives for that care. Transportation is obviously challenging for people who may not ambulate very well. Costs, families with special health care needs experience much higher costs and expenditures than required of healthy children. Dental insurance may not cover all the needs, especially in the cases of where maybe we have to go for a general anesthetic and there's a lot of work to be done, and that cost could be very high. Medicaid states, not all states provide adult Medicaid programs. Autonomy of patients is so important. Patients with special healthcare needs may not be able to advocate for themselves. Coordination of dental treatment goals with the family is crucial, and consideration to the parents' needs and wants is pivotal in success of any dental care. And just having proper informed consent for any of the procedures is important, just understanding why the patient is having the procedure and having those conversations with the parents. This was just another study that just stated over half the subjects had health problems were lacking in dental care and other types of care, and how that is prevalent. This was a study that just talking about general dentist perceptions and educational treatment issues affecting access to care with children with special health care needs, and just that a lot of general dentists are not comfortable treating people with special health care needs because of behavior, the level of disability, or their physiologic limitations. So this is just an update on disparities. There's just high unmet need on special needs kids, and it's due to these barriers. The costs are a major barrier, and especially in the state that we're in, adult Medicaid coverage is poor, and that just leads to treatment not being completed. Accommodations for cognitive disabilities is very important as well. So I like to stress to you is the community connections. Physicians should be familiar with community-based resources for persons with special healthcare needs. Local hospitals, public health facilities, rehabilitation services, or groups that advocate can be valuable contacts to help the medical provider and patient address barriers to oral health care. Finding that dentist in your community that is someone that is good working with special healthcare needs people and actually advocates for them is great. So I guess I was trying to wrap up really fast because I see that we're getting down to the last few minutes. Just some of the take-home points I wanted to point out. Medical health and dental health are interrelated. It's especially important to understand how oral health and general health affect one another. We should discuss the patient's needs with the dental staff prior to the appointment. That really helps the appointments go smoother, and we get more long-term, more time out of those appointments. Have the primary caregiver at the dental appointment is so important. Advise patients, caregivers of potential interactions or contraindications to dental procedures with respect to medical conditions. And acquire dental provider referrals that are equipped for patients with special health care needs. So important to find the right person to treat the right patient. All right. Thank you all so much for listening, and I'm looking forward to some questions.
Yes, thank you so much. That was great. I always look forward to the grand rounds, but dental grand rounds especially, because they're, I learned from the medical side of things. Learning about the dental aspect of things is always very new to me, and I think just as important. And like you were stressing, it's important that medical and dental professionals have a interprofessional relationship and communicate well with each other so that their patients can receive the best care. And I think that's the more I'm exposed to clinical medicine, the more I find that to be true.
Great.
Does anyone have any questions? Like I said before, if you have questions, just click on the questions tab on your gray control box, your gray control panel. And while you guys write your questions, I'll remind you that you can download tonight's presentation from the Handouts tab. It should open up in a web browser, and then you can download it there if you'd like to have it saved to your computer. In addition, on the flyer that you received to allow you to register for tonight's webinar, there's a link around the top of it. And if you click on that link, it'll bring you to the AADMD Virtual Grand Rounds YouTube page. and you can see all of the past grand rounds we've done, medical and dental. And this presentation should be uploaded in about a week. It should be up there with everything. So you can share this with your friends or colleagues, or if you're an educator, use it to teach your students, or use it however you think would be best. So we have a few questions in. Do you use SDF frequently on your IDD patients?
So we are using it more often. It really depends on the severity of disease. So we can use it as a place card, like a holding pattern if they're waiting to go to the operating room, because sometimes there's a delay between the diagnosis and the treatment. And sometimes we can use it on small lesions, root surface lesions. So we can use it. You just have to be careful with the dosing and you know, how often you're using it. And yeah, it's great.
And we actually have a grand rounds on sodium, sodium diamide fluoride. And as soon as the
silver diamine fluoride.
Silver diamine, that's it. And as soon as the research is published, we'll have it uploaded. Next question asks, to what extent have special needs dentists provided education and or served as a resource to FQHC dentists, given that the FQHCs receive a higher Medicaid reimbursement? That's a complex question.
So that's a good question. Yes, no, it's a good question. Typically the FQHC, the federally qualified health centers, will see persons who maybe don't have full dental coverage. So it's a sliding scale, so it's a great resource. So, and I don't know as far as, you know, dentists being hired there, being general dentists, it would really depend on what their training background is. And teaching them, I think that it's always fantastic to invite speakers in. If there's someone in your community that does treat special healthcare needs, or they kind of specialize in that area, invite them in to come talk to you, and invite them in to come talk to your staff, or maybe you can go observe them in their office. I think it's a fantastic resource and opportunity.
Thank you. So our next question is, what is your opinion on the use of IV sedation in patients who will need comprehensive dental care, like restorations and scaling?
So it depends. So if IV sedation is moderate sedation typically, depending on what drug regimen you're using. So I've seen IV sedation used where they do a propofol drip and the person, a special healthcare needs person, is kind of in and out of consciousness. So they maintain their protective reflexes to a certain degree, but they are being sedated. So I've seen scaling root planing done in that environment. In my training, if the airway is open, so if you're doing IV sedation only, there's no LMA, no laryngeal mask airway, there's no endotracheal tube, there's nothing kind of protecting the airway, then I was trained not to do those types of procedures in that environment because of the risk of aspiration of the debris during the procedure. So the procedures I will typically do will have a rubber dam, and that's a dental dam that actually protects the airway from debris falling back. As far as exodontia, like extracting teeth, you can have blood that can go back and potentially cause laryngospasm. So I guess doing comprehensive work as well can be time consuming, and you run to your maximum limits of drug dosing for IV sedation when you go past a certain amount of time, depending on the size of your patient. So there are a whole bunch of things in there. I've seen people do it very safely and effectively who are very competent individuals, and then I know and I've heard of stories of just not good things happening. So knowing that you have a fully trained dental anesthesiologist or your regular anesthesiologist, and knowing you have the proper emergency tools around you, and you know what your emergency plans are, I guess it could be done effectively. I'm not a fan of it, just because I worry about the safety of the patient.
Great, thank you. So our next question asks, family physicians are encouraged to do screening dental exams on young children. How should these screening exams be modified? For example, in rural areas where physicians may be using dental sealants.
Oh, well, I didn't know they were using dental sealant. So how can they be modified? So you're saying, you're asking if they can use them or they are using them?
So they are
the dental sealants.
As far as I'm familiar with. I think it's a relatively new a new thing. It's I think with the Medicaid expansion, physicians, family medicine, and pediatricians began using sealants in their office. Especially, it was to help populations where people might not be as likely to
have no access to care. Yeah. Right. Well, I think that primary care physicians can be great oral health care providers as well, and for obvious reasons. But I think that especially in those environments, it can almost be like a triaging where your primary, your pediatrician or your physician, internal medicine physician, whoever, is kind of triaging patients. So if they can get familiar with identifying carious lesions and abscesses and things like that, they would know which patients need to go to the dentist. And the ones that, generally have reasonably good oral health, they can do things like provide fluoride varnish or sealants. I was not aware that they could do.
I think
and even SDF. Yeah, fluoride varnish is something that they've been doing for a while, and that's a great thing. It's a great tool. I think that it should be incorporated in all pediatricians' offices, but maybe that will be in the future.
Thank you. So let's see this next question. Let's see. Let's go to this next one. I figured that last question out. What desensitization techniques or plan do you use on patients with ASD or mild, moderate, or severe?
Okay, so for mild, I for the most part, I'm making eye contact. I know it sounds very simple, but I think it is so key with ASD patients, and it's almost my gauge to know how far I'm going to be able to get with them, because capturing their attention that way, because I work primarily with younger children, but if you can't get that eye contact, then you kind of know that they're just pretending that you're not there and they're not going to follow very many directions. But so what desensitization? So with your higher functioning people, I bring them into the operatory, let them touch, let them feel everything. Maybe don't make them sit down right away. So let them touch the rubber cup, let them hold the mirror. With a moderate, I might use some key facts from the parent or the caregiver, like, oh, they really don't like X or they really love Y. I have no problem with unabashed encouragement and flattery or whatever I need to do. So if we have to talk about, a subject, if somebody loves trucks, I will talk about trucks through the whole appointment. But bringing them in, again, you might not expect them to sit down on the first appointment. You might expect them to explore the office a little bit or meet the staff. With severe ASD, it's more challenging. So I've seen successful conversions with patients that get used to the environment and get used to the people that they're working with. So it becomes a familiar space. And I've actually had patients that will fall. So when we do desensitization, you build on the steps. So today we walk into the office. Tomorrow we walk into the office, we sit in the chair. The next day we walk into the office, we sit in the chair. We put the mirror in the mouth. The next time, we keep building, but we keep doing the same sequence of events. And so I've worked with kids like that, and I've actually, gotten comfortable with a few of them. So I slip a little bit, and I've been pointed out by my patients, like, hey, you didn't do this in this order, you know, you need to back up and do that again. So it can be successful. The papoose is something that is a hard thing for a lot of people. They don't like the idea of the restraint, but with ASD, that deep pressure sometimes is like a circuit breaker. You know, it shuts down all of that energy. And they use deep pressure. They use deep pressure machines. They have deep pressure blankets that they'll use for some of those persons. And I can't, you know, say enough that sometimes we put those kids in the papoose, we put the Velcro around them, and they just like, it short circuits, they're done, they're good, and they'll follow commands at that time. So it's hard because those patients, you know, they vary, and you know, it's a little bit of a learning curve when you're a provider. You know, one size does not fit all.
And our next question was actually about your position on using papooses, but like wrap stabilizations. But
Yeah.
My question would be: are those provided by the office, or is a papoose or a wrap stabilization, is that generally something that the care providers bring?
Oh no, usually in the dental offices we have them.
Okay.
Yeah.
Right.
So they're a tough subject. There are a lot of people that don't think that they're appropriate. I think that, you know, you have informed consent, you describe the procedure to the parent, and you make sure that the parent or the caregiver or, you know, or they're on board with it. It should be a cooperative decision, you know, that everyone's comfortable with it, and you know, it's used for appropriate things. It shouldn't be a routine that you just stick every person with ASD in a papoose. Mm-hmm. You know, it should be appropriately used for the appropriate patient.
I think also asking what methods they use to calm down the child in school settings is a good idea. I know my sister, they also often used a weighted vest for her, which she happened to like a lot.
Right. Yeah. Yeah, it can be very successful, and sometimes it doesn't work. Mm-hmm. But you know, the longer you have a relationship with these patients, you know, the better suited you will be to caring for them.
All right. Well, this time we don't have any more questions, so I think that say thank you very much, Dr. DiStefano, for taking the time.
Thank you.
For the presentation.
My pleasure.
If anyone has any questions after the fact, they have my email. It's on the flyer. Feel free to reach out to me. And tomorrow you'll receive the email with the post-presentation survey. And if you'd like to download the presentation, feel free to do that. And with that, I'd like to say thank you everyone for joining us, and have a good night.